Good morning, good afternoon, good evening. My name is Rosana Rivas, IFMBE Clinical Engineering Division Board Member. I'm so pleased to welcome you to Hacking Coronavirus Project, Tackling COVID-19 and Beyond, webinar which is supported by Clinical Engineering Division of IFMBE and Global Clinical Engineering Alliance, GCA, to promote education, collaboration, and clinical engineering information exchange. Just to advise, the Q&A button is available to set a question. It will be addressed at the end of the presentations. Comments are welcome in the chat. Please keep all your microphones mute among the session. Thank you very much. Let's go now for a brief introduction. Okay. Let's take a introduction look to what is going on with this amazing, valuable, and high impact project. One of the best efforts that are aimed in this project is to provide, search, share knowledge. This knowledge, scientific knowledge as a background for clinical engineering intervention, is facilitated to support healthcare interventions in the topics of management, innovations, diagnosis, etc. This is another value of the project because the focus is on actions in the interventions and knowledge to be sure that your valuable interventions as professionals are well supported by a solid background of knowledge updated. Second aspect is the global network. Hacking Coronavirus 19 project has a newsletter. It is accessed by more than 17,000 global subscribers, and they are engineers, physicians, staff of Ministry of Health, of course, advisors, consultants, and staff of WHO, technicians, etc. This makes an amazing high impact visible for the results of the amazing projects, Hacking Coronavirus 19. The third aspect is communities engagement. The communities based on engineers, physicians, health technology managers, technicians, all of us working in the site. The social media strategy is successfully improved by the team led by Luis Fernandez. He's going to be with us in some seconds. And it is a strategic network that is improved constantly through this strategy, social media one. Finally, my pleasure to present the team. We have an amazing leader, Elliot Sloan. I have no words to describe his high value, not just as researcher, professor and colleague, but also as a member active in the site of how to make solutions or support other solutions globally to COVID-19 and beyond COVID-19. It's time now to set the floor for the first presenter. Thank you very much. It's my pleasure now to introduce Elliot Sloan. Elliot is the chair of Global Clinical Engineering Alliance, GCA Foundation. He's president also of Foundation for Living, Wellness and Health. Dear Elliot, the floor is yours.
Thank you, Rosanna. And thank you all for joining me today and for providing the opportunity to share with you some of the details about our Hacking Coronavirus newsletter and all the work that we do as a team and community to make information and knowledge available to our clinical engineering colleagues around the globe. So I'm going to cover these topics fairly quickly. These presentations will be made available to you after our webinar, and I'll be glad to answer questions individually. I have my email address at the end. As soon as the pandemic began, we realized that there is and was and will be a tremendous amount of information needed for clinical engineers around the globe. Also, we realized that managers, ministries of health, hospital administrators, also physicians and nurses and other caregivers needed enormous access to information. And so we started immediately to gather this information together. Over the 30 months or so, we've published nearly 650 issues, and 4,000 to 5,000 citations are available. And I'll explain all of that to you shortly. This Hacking COVID program and newsletter is free. There's a link provided that will allow you to register and get your own free copy every weekday. And the topics are in these items 1 through 7. We've really tried to hone in on clinical technology assessment, management, and patient care issues. Now, what happened was shocking to everyone in the information and library sciences and research field. A tsunami of papers hit the press, the scientific press. There were articles, research articles, describing how many different sources of information were flooding from around the world, and conquering that was impossible. In the first year of COVID-19 publications, the numbers went from a near zero to hundreds of thousands of articles, a lot of which were what we call gray literature over on the right, that top section. Those are journal articles, newspaper articles. Some of them are really extraneous, but many of them point back to the original research, say by the National Institute of Health or a Ministry of Health. So we really focused on the Ministry of Health information. We also did not focus on the unpeer-reviewed papers, the non-peer-reviewed papers in what is called the preprint. We focused on peer-reviewed papers. Here's another example of the topics that were covered. Many issues in public health, hospital mortality had topics and technologies like ventilators, pulse oximeters, patient monitoring, telemedicine, telehealth. On the left is diagnostics and testing. All of these are of great interest, and they're really core competencies for our clinical engineering colleagues. There has been a sense that in 2022, the number of publications may top out because the vaccines, the pandemic has sort of ebbed around the world. However, I can tell you as the primary curator and reviewer of the literature, there is a lot still coming out. For example, countries that have not published in the past, like Iran, are just now having an opportunity to bring their articles to the press. So these, I'm not going to go over these statistics, but they're available for you to look at. So many different areas came into play, as you all know, because you, I, everyone around the globe personally and professionally experienced this horrible pandemic. Here are some examples of the topic areas. This is a publication that looked at what are the areas focused on and the percentage in different topics. I put stars next to the devices area. But there are really even more stars that really are appropriate. These are just the immediate ones that came to mind as I wanted to illustrate the interest. Now, a really extraordinary breakthrough that happened in February of 2020 is the World Health Organization asked the global community, actually the Wellcome Trust, which is a nonprofit organization in England, asked all the world publishers to make available all of their literature without a paywall. We also immediately recognized this is the first time engineers around the world, no matter what country they were from, could access primary literature from Elsevier, Wiley, Francis Taylor, and other sources in full detail, not just the abstracts. So we took it upon ourselves as a team. Rosanna indicated the members of our team, a global team, to curate, organize, and publish this with the help of IFMBE and support of the Global Clinical Engineering Alliance. So who creates the newsletter? Well, as it turns out, I do most of the journal searching. My eyes are a little tired after 2.5 years of looking through tens of thousands of articles to find the ones that are relevant to our clinical engineering profession. Technologies and the like. applications of technologies, and also public health issues. Luis's team handles the citations, repository, and also the draft issues. I look over all of the draft issues and make suggestions. Our editorial board also makes suggestions, comments, corrections, and revisions. And then after we have published the issues, Luis's team adds them to our archives, which are available to all of you for free. What the Hacking COVID newsletter is and is not. What we included is technologies and processes that affect diagnosis and treatment, also innovations in technology and patient care. Over the last 2.5 years, for example, all sorts of new telemedicine innovations, new diagnostic test, mobile testing, home care were all innovated. Peer review articles of all sorts from as many languages as, unfortunately, I'm limited to English, so predominantly English language sources, and also we excluded, as I mentioned below, preprint or non-peer-reviewed articles. So opinion pieces, policy pieces made by a right or left wing a person or personality or group. And we also avoided the topics that have enormous controversy, such as hydroxychloroquine or ivermectin. It's so hard to get to ground truth that we excluded those from our publications. In-scope examples, pandemic health technology assessment and management innovations and applications, low and middle income countries, solutions, innovations, challenges, and issues. Moving further down, patient care best practices, repurposing of technologies like CPAP and BiPAP units for ventilation support out of the hospital, home care, telehealth, telemedicine, AI, machine learning, all of those were in scope and continue to be in scope. Again, out of scope are the gray literature, the breathless hype, the claims by vendors whose products have never been tested, products that have been denigrated in the market, etc. Also, we have not looked at the very interesting but complicated issues of training physicians and nurses and other allied health professionals. We also did not look at social networking, social media topics such as who is using Twitter or Google to find information about pandemic solutions. Sometimes we've included letters to the editor if they're actually short letters that include references, diagrams, research reports, because different publications limit or require at least 5 pages or 10 pages for a full article. So we look very carefully at all of the resources that are available. Some engineering, research and development papers and reverse innovation articles. Adaptations of technologies in low and middle income countries is very important to look at for all countries and participants to see if they can be repurposed and used in other settings. And also some manufacturer documentation and training we've shared. Where does the information come from? Scanning all week, every week, looking at all of the repositories around the globe. There are a number of indexes, but they are not always complete. Those depend on the publishers to input information to, for example, the National Library of Medicine's PubMed. If the publisher does not have the time or energy to upload or only uploads once every quarter or every 6 months, that's not good enough. So I go to the actual publishers' databases, search for all articles on COVID-19, and then read through all of the abstracts to determine which ones are relevant for hacking COVID. Serendipitous discovery is also part of this. So articles come in the press, New York Times, Wall Street Journal, and they refer to a recent published report in the Lancet or the British Medical Journal. And then I go find that original article to cite for our individuals. As I mentioned, I only speak English, and therefore there are probably some limitations, but most foreign language articles are also at least keyword indexed in English so I can find them. The citations are harvested day in, day out, week in, week out. Sometimes it's a 4 or 5 hour session. Sometimes it's a half-hour session. Really, we have not had much input from the community, the community. We would certainly welcome input from each country and each clinical engineer about innovations or articles that you're aware of that we should add to Hacking COVID. We're not restricting it to my work or our work. And there's a link here for email that allow you to send information to us for us to consider for inclusion. We have two different sections in Hacking Coronavirus. One is for clinical engineers. It's really focused on the things that are near and dear to our hearts: the technology assessment, the technology management, oxygen therapy, home care, telemedicine, the applications and emerging applications of artificial intelligence and natural language algorithms, advanced care modalities like ECMO and convalescent plasma. And also some articles related to managing the stress in the workplace that has affected everybody, dealing with burnout, fear, and the like. The C-suite is focused more on executives that are dealing at the Ministry of Health or hospital management, often dealing with population health issues like COVID screening methodologies, or in some cases, various masking policies. Again, because vaccines have been so complicated and localized, we've not covered that very much. Staff training, faculty training, the long COVID issues, which are now emerging in the literature all around the planet, are of great interest to the C-suite because that affects the ongoing care of the communities and population, and also affects the economies of various countries. How is hacking coronavirus? How do we deal with quality control? We have a set of self-governed rules. We look at the abstract, but we also look at the authorship. If the authors are all from a vendor, we generally don't publish that. That's usually like an infomercial. It's representing the opinion of the manufacturer. Also, hacked devices or homemade devices that are not medical grade, we don't include information about that. I mentioned before, we aren't including preprint server information nor gray literature information. We try to provide the best information possible. Sometimes, however, articles 6 months ago are only indexed or visible to us when we're scanning today. So we add them if they're appropriate and relevant and add to our knowledge. We started looking at patient tracking and disease tracking, but as that field exploded, I think there are almost 100 different forecasting systems out there. They all have different information. They're all very hard to trust or figure out what truth is, so we decided to exclude those from this. Enforcement is simple. If any member of our editorial team is uncomfortable with an article, we simply don't publish it. There's no reason. There's such a wealth of information. We want to give top quality, first-rate information to all of you, our clinical engineering colleagues, and your teams, and make it easy for you to find information without having to do what I do, scanning all the world's literature to find what might be relevant or useful. So future directions. There are so many topic areas that are of interest to us in the coming years. As we look at monkeypox, for example, how could we or should we apply telemedicine or machine learning or artificial intelligence for diagnostics or treatment? Electronic medical records and replacement of paper records, forecasting of patient care, home care, virtual hospital, remote patient monitoring. There's so many articles that are out there that have been published and available for us to read in the original full source to take advantage of. All of our databases are available, all of our articles are available for free at the link that I provided here. If you want to find information about oxygen therapy or low-flow nasal cannulas or diagnostic methods or tools, you can go to this website and find the articles, and they will link you directly to the free full PDF or text of that article for you to do your own research. Future directions, we also would like to do some a living repository of this information, perhaps moving on to other fields like pandemics, Ebola, monkeypox, for practitioners, for researchers. We've talked about a grand challenge to look at how can we harvest the lessons from these data sources for, say, AI or machine learning, and research and publish about lessons learned from the pandemic. We all have lived through an astonishing scientific and medicine and policy revolution, and what can we learn from this to deal with what we know will be a future pandemic? So again, thank you for the opportunity to share the work we've done. Thank you for the opportunity to serve all of you around the globe. You can reach me at ebsloan@gmail.com, and it's a privilege and pleasure to be with you today and to have the opportunity to have created and support ongoing this Hacking COVID initiative. Rosanna, back to you.
Thanks much, Elliot. You absolutely make a great contribution in this amazing project, the principal leader and the amazing visionary of one of the most high impact projects CED-IFMB has now in the background. Thank you. Let's now give the floor to Tom Judd. Tom Judd is past board chair of IFMB Clinical Engineering Division, member of Global Clinical Engineering Alliance, GCA Founders Council. Also, Kali Roy Estabriano, she's going to be part of the presentation and the following presentation. Kali Roy is board co-opted member of IFMB Clinical Engineering Division and Secretariat of Global Clinical Engineering Alliance Foundation. The floor is yours. I believe we need an adjust. I cannot listen the sound.
Kali, we still can't hear the sound. Samantha, can you play the video, please?
Sorry, Luis, it doesn't allow me to share my sound screen. I think that's the same problem that Calero is having.
So I suggest, Luis, to go to your presentation, and on the meantime, we will fix the technical problem, okay?
My pleasure. Just give me one moment.
Thank you. Okay, let me introduce you. Now we are gonna listen the presentation of Luis Fernandez. Luis Fernandez is a great collaborator of IFMB Clinical Engineering Division, co-founder and CEO of Think. And it's my pleasure to give you the floor, Luis. Go ahead.
Thank you. Can you hear me well?
Yes.
Excellent. Well, thank you very much. After a very nice introduction by our colleague Elliot Sloan about what is and what is not the Hacking Coronavirus Initiative, repository, and project in general, I'm going to walk you through the how we deliver this great and valuable content to clinical engineering collaborators. So first of all, I want to be extra I want to make extra emphasis on the importance of what this great team is doing, because not only have we been battling with a pandemic, we're also in the midst of a misinformation war where I'm pretty sure that at the beginning of the pandemic, we had a lot of doubts and we had a lot of information flowing in, as Elliot just mentioned, and that creates much confusion. And of course, that creates a lot of bad decisions. We've heard before, can we or can we not connect two patients to more than one ventilator because there's a shortage of ventilators, XYZ, right? So what we intended to do is what Elliot just mentioned, and I'm not going to go further into that, is just to contribute on the clinical engineering side with selected content, curated content, being just double checked by experts on this side, and just filtering a little bit on what we could do on what is available on the web and being delivered to you. So our content experts, of course, Elliot Sloan, who just presented, but also involved is Tom Judd, Yadin David, Rosana Rivas and Cali Roy as content experts who participated in evaluating this content, making sure that this content was relevant for clinical engineers, but also for other health technology related professionals. And on the, let's say, the marketing team or the digital platforms team, my colleague Irizia Peña was or is still, after more than 2 years, still the person behind the emailing campaigns that addresses and schedules the emailing campaigns with these valuable contents. Estefania Cajigas, which is the person behind all the graphic design that is being done so that this content can only be received, but that is also a little bit better received on the user experience side. And myself, that takes care of all the back-end design of this, and also that makes sure that all of the digital platform works as it is intended to be. And also trying to analyze the trends behind where the clicks are being clicked, and also the contents that are being consumed, et cetera, et cetera. So this is the general process behind the construction of the Hacking Coronavirus project. So each of us in their own times, of course, we did the individual web scouting for content that may or may not be relevant to clinical engineers. So we proposed this content in a WhatsApp group, or by email, or by multiple channels. So we, as let's say, the experts, proposed the content by multiple channels, and then we generated a big repository of, let's say, candidate or proposed content. So this content gets assessed by the experts, which I just mentioned, and then that content gets, let's say, introduced into a funnel, and that funnel has multiple stages where that content gets discussed and gets filtered and gets selected, and the final content that gets selected gets scheduled into different campaigns that are scheduled for each of the weekdays from Monday through Friday. So each weekday we send out an individual campaign, which is divided into 3 main categories. So we have the content that is related to the clinical engineers, or is mainly related to clinical engineering resources. We have the content that is related to the C-suite, or that the general directors or the C-suite of, let's say, a hospital might want to know. And we also have a special section where we invite all of you to send us, your clinical engineering stories, best practices, or even images of you in the forefront. So that's what we want to portray. And of course, it's very difficult to find clinical engineering specific content, but we do try our best. But we also need the community to help us, just collect all of those and user stories about what we're doing out there and how are we helping our communities and also the hospitals. So when these campaigns get scheduled, they get sent out as well. And at the end of the day, these campaigns also get distributed on their social media. And these campaigns and the content within these campaigns get stored under the Global Clinical Engineering Alliance repository or website. So all of the individual citations, we have them stored under the Global CEA website. We have a special section for that in the website, and we update it on a weekly basis. Let me go to the next slide. So here are our 3 sections. So we have the clinical engineering at the forefront section, where we portray, it's just success stories, a small section to honor the clinical engineers that are on the forefront fighting the pandemic. And also, we try to also portray people that are in the front lines with pictures, with success stories, stuff that we find online in LinkedIn and in social media. And of course, we ask for permission to post all of this before we do. But we also invite all of you and all of your clinical engineering departments just to send us your pictures, your stories, because we want to get this out there, and we want to promote what clinical engineers are doing or have done during the pandemic. The CE resources, as I mentioned, are resources that are specifically designed for the health technology related professions or the clinical engineers. And at the end of the day, also the content repositories are very important, and the C-suite content related as well. These are the communication tools that we are using. So we use MailChimp for email marketing, and these are the social media channels that we use. So for example, Instagram, LinkedIn, Twitter, and Facebook to effectively distribute all of our channels. This is an image of the Hacking Coronavirus Project website within the Global CEA that you can all access as of today. It is open access and it includes all of the links. We update it weekly, so you can also access this content for free within the Global CEA website as well. And these have been the results so far as of June 2022, when this was presented in the IUPESM World Congress. So since April 2020, we've generated over 540 issues, and we grew up our subscriber database up to more than 18,000 subscribers. So what that means is that more than 18,000 professionals subscribed to that emailing list because they wanted to receive that content related to what we were delivering, which is a huge, huge milestone considering that clinical engineers are fighting the pandemic. Also, as a conclusion, we need more clinical engineering resources, of course, because there is a limited amount of available time. We've been discussing in Congress is the need for more clinical engineering literature and a small amount of time that we as clinical engineers have to effectively write this content down. But we also need, this material and these experiences to be out there. So as a conclusion, we need to speak up as clinical engineers a little bit more because the communication channels work. And also, this is a case of success of a mix of clinical engineering and marketing, because at the end of the day, our study shows that our emailing open rate is 47%. A small fun fact in emailing in general and email marketing, a good emailing campaign open rate is around 30 to 32% open rate, and we are around 47%. So that is really great news because our audience is really interested and also expecting our content week by week. So at the end of the day, this project after 2 or more than 2 years is still relevant, and this content and this strategy and this project and team is proven to have been working in the right direction. As Elliot mentioned, there is multiple other projects that can be worked upon all of this. At the end of the day, this is mainly free time with a good intention from all of us that have been involved for this and towards the same goal for the past more than 2 years. And this is all worked upon just because we want to help the clinical engineering community. So if any of you has a good intention or a good project or a good idea that this database may serve as a good basis, it would be very, very nice to hear what you have to say, and also for your ideas to flow to Elliot's direction, because I think that he might be the best person to talk to. We've heard multiple ideas about artificial intelligence. So what if we can map out, let's say, the keywords behind this trends? There are numerous projects that can be handled or created behind this. So we expect for this to serve as a basis project for other entrepreneurs, for our other innovators, and as well that it can be useful for future research projects. So thank you very much, and back to you, Rosana. Thank you.
Thank you, Luis. As you could observe, it's an amazing contribution by the side of all the social media strategy he is leading in the project. Absolutely amazing. Let's go now to Tom Judd and Kali Roy Estabriano presentation. I did the introduction already, so we're going to listen to the video and confirm, Kali, if everything is okay. Go ahead.
Well, good day, everybody. Tom Judd and Kali Roy Estabriano here.
Perfect.
Speaking about the Hacking Coronavirus Project and Global Clinical Engineering's pandemic response and resources and future directions. The thing we're going to talk about specifically today, the perspective we're going to offer, is the institutional professional approach. Yep, it's Tom here, and I'm so pleased to be with Kali Roy.
Hello, everybody. I'm very, very honored to be here. And I also feel very honored that I was selected by you, Tom, to serve as the Clinical Engineering Division Secretariat during the last 4 years. In this secretariat role, I was mainly involved with organizational and administrative tasks. So I would say that in this Hacking Coronavirus project, I was an observer. So as an observer, I would like to state that these meetings were taking place daily for more than 2 years. And this group's commitment and participation was amazing, as they devoted their free and spare time daily, even when they were not feeling well or even when they were COVID positive. Imagine that. Their devotion for this project was extraordinary, and I would like to express my admiration and how much this group of colleagues have inspired me. Back to you, Tom.
Thank you. I mean, you guys already heard on the webinar today from Rosanna and Elliot about our team. I'm not going to elaborate that team other than to say, how do we get started? And many of you know the story. Adriana Velasquez from WHO called Dr. Yadin David and I near the end of March. WHO was getting inundated with the beginning of COVID challenges, asked for the global CE community's help. And we said, good timing, you know, our board and collaborator meets of CED next week, that last week of March. And during that last week, Dr. Elliot Sloan came to Yadin and I and said, so many articles coming in, you've heard that story. We need to start this initiative, the Hacking Coronavirus Initiative, the weekday daily e-newsletter to assist our colleagues around the world. And so we did. And you know what happened since then. And of course, you know when I talk about the global clinical engineering community, I'm talking about IFMD Clinical Engineering Division and the Global Clinical Engineering Alliance, CED and GCEA. So this is the perspective, our approach. And quick overview of what I'm going to talk about here with Caleroy briefly. You know, we created a knowledge network in response to COVID to share best practices around the world. You know, we didn't know we were going to do this, but we identified and encouraged regional and national heroes, clinical engineering heroes, for a wide variety of country responses. The centerpiece, of course, was that daily e-newsletter, something like 620 issues out so far in the last 2.5 years. Actually, yeah. Summary, we're going to look into hacking response and how it has been and is relevant to the global community and our priorities, as well as some future directions. So the knowledge network, many of you have seen this slide. Once again, the centerpiece is the hacking newsletter that comes out daily. But we've done more than 50 webinars on critical topics, best practices around the world. Many of you are familiar with that. We shared Adriana and the various priorities around COVID with our monthly board and collaborator meetings. We published Adriana's newsletters and shared them widely. And of course, we also had a daily Q&A and problem-solving WhatsApp group that has grown very large. Wow, I mean, you know, the real story is when the times got hard around the world, and they did. You know, many of our family members, many of our friends, you know, were hospitalized. Some of them died. You know, many challenges. Some of our colleagues made real-time interventions in people's lives and made a difference. But we do want to honor these emerging leaders that we've talked about in recent months. Those from Nepal and Bangladesh, Japan and China, in the Western Pacific, Southeast Asia first, Eastern Mediterranean, also Middle East, North Africa area, from Pakistan and Kuwait. Great leadership from Europe, from UK and Italy notably, and from the African region, Rwanda and Ethiopia, as well as our own Americas here from Haiti and Peru. So proud of these individuals. You're seeing the names, congratulate them when you can. But the hacking e-newsletter we're talking about today and the perspective of the global CE community. Elliot's already talked about the topics that were captured, several thousand on the GCEA website and our repository. So many clinical engineering issues were embedded in this slew of information on health technology assessment, management, all the oxygen systems, all the respiratory equipment needed in COVID, and digital health issues, and many more issues. So this is what we gave back to the community as the global community. What did our newsletter have? You know, this is a little bit redundant perhaps, but what were the relevant topics in the scope of this project? Certainly innovations, not only HTA and HTM, but innovations and applications, best practices, low middle income country solutions and innovations, challenges and issues, COVID diagnostic methods, lab imaging and testing. What comes to mind is that project that Dr. Dan Clark there in UK, where his team there in Nottingham worked with pulse oximeters to make sure they were accurate, got them out to the country so that people who couldn't tell that their oxygen capability was decreasing day by day could get in and get seen and treated quicker. Patient care best practices around oxygen therapy. Not everybody needs a ventilator. So how do people slice and dice and provide the right tools for patient care? Facility best practices around infection control and isolation, emerging challenges around long-term COVID, and then digital health, how it made a difference during this time and what clinical engineers could do with that information. There were also general articles clinical engineers need and can use in their daily professional work. And, you know, maybe I'm repeating some of what Elliot said. CED was behind this project. GCEA was behind this project. They were part of the team that looked at this information every day and provided it to you every Monday to Friday, the last 2.5 years. So direct patient care and safety, HTM and A, COVID topics, digital health, and so on. So some of these came from outside of, most of these came from outside of clinical engineering, but they applied to us. And so they were a little bit indirect, but they made a difference for how we could communicate with our leaders, which actually leads to the next slide. How, armed with this information from the hacking initiative, clinical engineers could go to their hospital administrator, could go to their minister of health, and make a difference in the planning and response of the countries. Triage centers come to mind, safe discharge to home after care, best use of oxygen in facilities, public health issues, population health around PPE and disinfection, digital health to know who was being treated, when they'd been treated, prepare different sites like nursing homes to take the best care of people and protect the patients, long-term COVID and rehab issues, and so on. And wow, what a big issue that last one, clinical and technical staff stress and burnout prevention and communication. So this is the kind of stuff we put in your hands in the global clinical community to help your health leaders make a difference day by day. And we still are doing it. So in summary, this not only helped outside our community and global healthcare, but it also helped our own community as we continue to build our capacity. These are our priorities for the global community that came out of our virtual program last October during Global CE Week. Capacity building specifically around improving, as you've heard me say, a country's COVID-19 response by clinical engineers. And it's making an impact. And we see those through the lives and the stories of the emerging leaders, reducing COVID's impact in those 12 countries that were identified. Credentialing, another one of our priorities this year is what are the new skill sets we needed, not only in the LMICs, but in the developed countries. All of these, not only respiratory medical devices, but also digital health tools, as we talked about, oxygen sources, not just oxygen fed equipment, but the sources of and personal protective equipment. In the context of this, many countries, Elliot Sloan predicted this back in 2019 in Rome, but we needed national telehealth policies, and telehealth, of course, became a huge form of giving care during COVID. We needed better regulation. I think of the ventilators that the countries needed, and they needed to create emergency use authorization around ventilators so they could get them into patient care, but still be safe. and then oxygen policy so that there was enough oxygen to go around to take care of the patients in a particular country. And of course, since the beginning, as I started with the story with Yadin and I and Adriana, we partnered with WHO. It was a priority. We continue to do that. So Callie, as we think about the future action plan, let me talk about a couple of these and you talk about a couple of them. We're not done yet. I mean, what have we learned from the hacking initiative that's ongoing is that this can be used to encourage the global clinical engineering community, both individuals and societies, about COVID responses and solutions. We can continue to use the hacking database for research. Elliot's been working with our 3 clinical engineering interns, all graduate students, evaluating some of the digital health resources from that hundreds of articles in that database, thousands actually. And we can take advantage of this dialogue with the ministers of health that our response has generated. Minister of Health are coming to clinical engineers now in several countries like Tazeen in Pakistan, who helped the Ministry of Health during COVID in a variety of ways. Now she's being asked for help and we're coming around her in policy development. Calroy?
Clinical engineers should publish more. If there is a global clinical engineering journal dedicated to the global CE community, so that all clinical engineers can contribute their stories and their results. So please visit Global Clinical Engineering Journal in www.globalc.org. Also, monitoring evaluation is really important, and therefore we can use tools like the hacking database, the WhatsApp group, and webinars like this one in order to fine-tune and guide the solutions and thoughts. So in order to conclude, true success is all about working together towards meaningful goals and dreams. And persistence and commitment really makes the difference. Thank you, Tom.
Callie, it's a joy to be with you here today, even though you're not feeling well today. And thank you so much. And we look forward to the questions that come tomorrow. And here's our contact information. Thanks again.
Thank you all.
Thank you very much, Tom and Calroy. We are going now to listen per chat or to read per chat some kind questions you could or may send. And I invite you now to all my colleagues and members of the team, Elliot, Luis, Calroy, to set on your videos for the last comments and the panel. Go ahead, Elliot.
Well, I really would invite the participants and anyone who views this webinar in the future to give us suggestions of how we can best support you. Ideas that come to mind for me are almost open-ended. For example, I would love to have a virtual library for clinical engineers around the globe to read technical articles that are relevant to our field. Beyond the pandemic, the fact that the publishers agreed to a paywall, a free paywall access or no paywall access, I would like to figure out a way for us to have a library card that would allow our clinical engineers to access this. I would also allow to have, or would like to have a way for our students to access this information. You really can't glean enough information from an abstract. It's almost a teaser. If someone talks about a new artificial intelligence or machine learning algorithm, you have to read the actual article to find out whether they really tested it on patients, how many patients, what the limitations and constraints were, etc. So that's just an example. Please share your ideas. I also will throw out the concept of a grand challenge. I would invite our colleagues in the academic or industry world to work with us to stand up some grand challenges, tools that allow us to harvest information that could be used for the next pandemic, that could be used to inform our practice. Back to you, Rosanna.
Let's now listen to some comments from Luis from his corner.
Thank you, Rosanna. I believe that this team has done a marvelous job. And as Tom said and Calroy said, I believe that it was Calroy who said that first. either we're feeling good or bad, or it doesn't matter if it's even the weekends. We've been there working for over 2 years so that our colleagues as clinical engineers can enjoy this content and can use this content for further projects to increase their productivity and to save lives. Really, that's the end goal of this project. We do it because at one moment at least in the case of my country, Mexico, we lived this situation with H1N1 over 10 years ago. And really, there was a need for this information, these resources. And I believe that one thing is to say that we don't have it, and the other one is getting your butt up and doing something about it. And that's what this group is doing. And I really just want to say that I'm really proud and honored to be working with these giants that we have here in this group. And also a word to make secondary motion to what Elliot just said. Hopefully this work will serve as a basis for future projects. I believe that this is not only serving our colleagues in the front lines, but will also serve for future projects, because especially Elliot has done a wonderful job surfing the web, searching for content. And Rosana, Yadin, Tom, Caliroy, myself, Irizea, Estefania have all been working towards checking that content, making it available, and just putting it out there for you to consume. So hopefully this will be serving as a future project. And also I want to extend an invitation to anyone that is hearing this either in a video or live. If you want to participate in any GCA, CED projects such as the journal, or you want to submit your articles or your own experiences, or Global CE Week is coming up in October, so you might want to get in touch with GCA, CED, or any of us. There's going to be our emails in the presentations. We're going to reach out with the recordings once this is over. So just stay in touch. There's a lot going on, and we want to involve you in future projects and other activities that the global clinical engineering community and village is endeavoring. Back to you, Rosana.
Thank you, Luis. So true and pertinent. The advice is about engagement with the attendees. Thank you very much, by the way, for your attendance today. It is amazing the number of persons here listening, but we are looking forward to the next steps with our interaction in the future. The floor is yours, Cali.
Thank you, Rosanna. I would like to follow on Lee's comments, and I would like to express once again how proud I am of being part of this team. And I would also like to express my appreciation and admiration for all of you, for everything that has been achieved so far. And I'm also looking forward for further achievements in the future, because they're really essential and highly beneficial for the clinical engineering profession. Thank you all.
Thank you, Cali. Knowledge, commitment, ethics, and most of all, being sure that we are transcending through the best of each of us in benefit of the population. You are so welcome to join us through GCA and CED, IFMB projects and activities. Please keep communicated through the media. All the attendees will receive, as we said in the chat, the information, the video, and the links for you to be connected after this session. Have a very good day. Thank you very much.
Thank you, team, and thank you, everyone, for allowing us to serve and support you.
Thank you. Bye.
Just wanted to add before we leave, there are 2 questions in the comments. Iwa Zelenska wants to suggest we add a few words about experiences of clinical engineering collaboration with MOH in various countries. So I will believe that Rosana can answer this. But before we do, Ricardo Silva is mentioning, Rosana, I just want to tell all the speakers that they have done a wonderful job, and their leadership is an example of all of us who want to build a better health for the world. I am very proud of you all. Thank you, Ricardo. And Rosana, the floor is yours to address Eva, and if anybody else would want to add any comment, the floor is yours as well.
Yes, thank you very much for the intervention, Eva. Yes, these sessions, daily sessions, weekly sessions, included in a very important way MOH experiences, exchanges, challenges, amazing results sometimes we collected through the information of the articles, also the discussion between the team about the pertinence of these contents to be shared with through the newsletter. The interaction between clinical engineers, health technology managers, biomedical engineers with the government is a key component of our work, because without the support, without the interaction with government, even you are in the private sector, it won't work. Excuse me. I apologize because being all the time smiling, but I am very happy, truly happy to join with this amazing team this session today. You cannot imagine the kind of work, the commitment and the efforts joined just to be sure you, the community, our colleagues will receive the best. And this is the moment to give honor to all of the community of CD and GCA in the community of Global Village. Thank you very much again. Don't hesitate to send us your comments or further questions, and have a very good day. Thank you.